This conference will now be recorded.
Okay, so today's topic for discussion is snoring and sleep apnea. So this is one of the symptoms, snoring symptom, which most of the patients come to you that this due to snoring, my family members and the surrounding people are really getting irritated. So I need to get sorted out. So there are some terminologies you need to remember, like stridor. Stridor is the harsh, noisy breathing. Okay, so that is when there is an airway suppression or when an airway compromise is there at the bronchial level or at the tracheal level, you get a harsh, rough voice. So that is known as stridor. But whereas snoring is a noisy breathing, it's also a noisy breathing of a person during sleep. When he is sleep, if there is any airway compromise or due to some other reasons, that noisy breathing is known as snoring. But when he's awake and all, the harsh breathy voice is known as stridor. So this snoring disturbs the other persons around him. And there's another term known as stutter. This stutter is also a low-pitched snoring that is mainly seen during inspiration. And when the airway compromise is at the level of, when the airway level is at the level of nasopharynx, you get this stutter. So stutter is the low-pitched snoring when there is an airway compromise at nasopharynx. Stridor is at when at the level of trachea or the bronchial, and snoring is when while the person is sleeping and there is a noisy breathing is heard. That is known as snoring. So what do you mean by sleep apnea syndrome? Apnea is cessation of breath, right? When the person is not able to breathe, that condition known as apnea. And when it occurs during sleep, it's known as sleep apnea. So what do you mean by sleep apnea syndrome? When generally a person will sleep around 7 to 8 hours. So for example, if he is sleeping for 7 hours and he has a lot of episodes like cessation of breath, apnea is happening around and it should be there up to 10 seconds. If the apnea is there for 10 seconds and it repeats around 30 times in the sleep phase, then it is known as sleep apnea syndrome. So sleep apnea syndrome is characterized by 30 apneic episodes which last for 10 seconds each or more during about a sleep of about 7 hours. Means when a person sleeps for 7 hours, he has around 30 apneic episodes, and each episode will last about 10 seconds or more. Then that is known as sleep apnea syndrome. So I think you are clear. Snoring, stutter, stridor, sleep apnea syndrome. So these are some of the terminologies. We'll also come again. There are some more terminologies to understand this topic. One is apnea index. So apnea is cessation of breath. So apnea index is number of apneas per hour of sleep. Means in 1 hour, how many apnea the person is getting. So that is known as apnea index. And there's one more term known as hypopnea. Hypopnea is reduction of airflow. Some define it as a drop of 50% of the airflow from the baseline associated with an EEG defined arousal, or 4% drop in oxygen saturation. Means if you have measured the oxygen saturation before the sleep and it is around 99, and if it is falling up to 95, 94, then the patient can be considered that he's having hypopnea. Or where there is a baseline. Means when you take an EEG for a normal person, there is a baseline. If according to that baseline around 50% drop is there, then that person can be considered as a hypopneic. Okay, so hypopnea is reduction of airflow, that is a drop of about 50% of the airflow from the baseline according to the EEG defined arousal, or 4% drop in oxygen saturation. EEG defined arousal. If you need to you have to understand this. Means when we take an EEG, when the patient awakes from the sleep, then the EEG, some other waves are shown, and at that time the air pressure, means how much the air pressure is there, it can be measured. If that is below 50%, then it is known as hypopnea. Okay. So what do you mean by arousal? Arousal is the transient awakening from sleep as a result of apnea or respiratory efforts. When the person is sleeping and suddenly he has cessation of breath, that is apnea, or something or hypopnea that is there, and he awakes from the sleep. So that is known as arousal. When he awakes from the sleep, then due to apnea or respiratory efforts, then it is known as arousal. Arousal index is the number of arousal events in 1 hour, and less than 4 is considered normal. If a person is awakening only 4 times, less than 4 times in an hour, then it is considered normal. If he is awakening more than 4 times, then this arousal index is not normal, and we need to think about some of the diagnosis. Then what is respiratory disturbance index? It is the number of apnea and hypopnea per hour. So means how much the respiratory disturbance is there in a person. So how do you calculate it? We calculate it by by the index in the by the number of apnea and hypopnea. Means how many hypopnea he's having and how many apnea he's having. All these are measured by using some polysomnography or some EEG. We all use these some instruments to calculate how many apneas he is having, how many hypopneas he is having. We also use a pulse oximeter so that how what's the saturation level. um, and the normal respiratory disturbance index is less than 5. Okay, if it is 5 or less, it's normal. Whereas arousal index, if it's 4 or less, it's normal. More than 4 and more than 5, these are considered abnormal. So I think you have understood apnea, apnea index, hypopnea, arousal index, and respiratory disturbance index. So these are the terminologies you need to remember, because these will help you to understand this topic. Okay. So, what is snoring? So, snoring occurs due to airway obstruction during sleep in inspiration, causing vibration of the soft palate of oropharynx. So, when there is obstruction of the airway during sleep, while inspiring, it causes an vibration of the soft palate of the oropharynx. So, due to this vibration of the soft palate, a sound is produced. So, that is snoring. Generally, when there is no airway obstruction, you won't see any vibrations of soft tissue of the oropharynx. But if you are able to see the vibrations, then it is snoring. And sleep apnea may be classified. The classification of sleep apnea is central, mixed, or obstructive. Obstructive, as we know, it can be of various, but central is due to heart failure or brainstem lesion or trauma to the frontal lobe. And sometimes in this central sleep apnea, your snoring may be absent. So if the snoring is absent, but there is some problem at the heart, at the brainstem lesion, or also trauma to the frontal lobe, or due to heart failure, uh, sleep apnea is present, then that is considered as central. So central is defined as due to heart failure or brainstem lesion or trauma to the frontal lobe, and sometimes snoring may be absent. Now we need to understand the physiology of sleep actually to understand all these. Normally, the sleep occurs in 2 phases, and a normal person sleeps for about 7 to 8 hours. 7 to 8 hours of the sleep is considered as normal. Okay, and we have two types of phases. One is REM phase, and then another is NREM. What is REM? REM is rolling eye movements. Rolling eye movements is REM, and non-rolling of the eye movements is known as NREM. And these occur in alternating cycle, which last around 1.5 minutes. Each phase will run around 90 to 120 minutes. And for normally in the whole sleep cycle, we have around four repeated cycles like this. So we have an REM phase, NREM phase, and that will last for about 1 to 2 hours. And we have a total 4 number of cycles in a normal sleep cycle. Okay. And we dream it. We have dreams, right? So those are generally seen in REM phase. So now we'll understand what is REM and what is NREM. Actually, NREM consists about 75 to 80% of the sleep, whereas REM sleep is confined to 20 to 25% of the sleep. So 75 means around 3/4 of the time you are sleeping, you are in NREM, and only 25% you are almost in your REM phase. So NREM is again divided into 4 stages, that is NREM 1, 2, 3, and 4. So you can see here, this is the drowsy phase, means we get drowsy. First initially we get drowsy, and then we go to bed. When we go to bed, means from the wakefulness state to the sleep state, that is NREM. So when we first fall asleep, we enter non-rapid eye movement sleep. So that is NREM 1. It generally it is around 2% of the sleep. NREM 1 is generally 2% of the sleep. Okay. Then NREM 2. NREM 2 is a bit a long phase. You will be entering slowly when you start from NREM 1, 2, 3, and 4. When you reach the 4, you reach the deepest part of the sleep. Means at that time, at that stage of the sleep, you are at the deep stage of your sleep. The chances of awakening means when you come from the means when you arose means like when you come out of the sleep, chances are more when you are in NREM 1 and NREM 2. Means the first two stages there are more you easily get up. When you are NREM 4, you cannot get up, means you are in the deepest part of your sleep. Okay. So starts with NREM. Okay, so it start with NREM 1, wakefulness to sleep state, that is 2%. Then NREM stage 2 is around 45% of the sleep is you are in the NREM stage 2. And then NREM stage 3 is seen, that is around 10% of the sleep is seen. You slightly go into the deepest part of the sleep, and then the last is NREM 4. That is a deep part of the sleep, that is around 5% of the sleep you are in deep part. Then starts your REM sleep. REM sleep is then your the rapid eye movement, rolling eye movements will be there, and this is the phase where you will have dreams. We have two types of one is nightmare and one is night terror. Night terror is seen in NREM sleeps, whereas nightmares are seen in REM sleeps. Okay, nightmares. You have nightmares. Many of the people have nightmares. So nightmares are seen in the REM sleep, and this is the phase where the muscular movement is very much less. So, and the muscular movement is more in NREM sleeps. There is a difference between that. I'll show you. So REM sleep and NREM sleep. Eyeball movements are rapid in REM sleep and absent in NREM. Dreams occur in REM, whereas NREM they don't occur. Muscle twitchings occur in REM. They doesn't occur in NREM. Blood pressure fluctuates, heartbeat fluctuates, respiration fluctuate, and body temperature. All these get fluctuate in REM sleep. But NREM, which is about 75% of the sleep, you have a stable blood pressure, you have a stable heartbeat, you have a stable respiration, stable body temperature. Okay, and dreams, muscle twitching, eyeball movement, these are all are absent. I hope you have understood. So we have two phases, NREM and REM sleep. NREM is 75% and REM is 25%. Okay. So if you have understood this sleep cycle, then due to some alteration in this sleep cycle, there are some causes like which alters the sleep cycle, and you have some symptoms like snoring. So the causes of snoring. The most common cause in children is hypertrophied adenoids and tonsils. So in children, if the children are coming to you for the complaint of snoring, the first thing you need to rule out is hypertrophic adenoids and tonsils. Whereas generally snoring is the chief complaint mostly seen in adults with who are very obese, by like morbid obesity more than BMI around 30, they come to you with snoring. Those who have thick neck, short neck, they come to you with the snoring, and generally more than 40. 40 years, 40 years male who's obese, who has thick neck, is coming to you with complaints of snoring and some other symptoms, then you have to you have to diagnose him as obstructive sleep apnea or something. Then you have to investigate the case. The persons who consume alcohol more are also predisposed to snoring. Okay, so the persons who do binge drinking, they are also more prone to get this sleep apnea. Drugs like sedatives, hypnotics, antihistamines, antiepileptics may also contribute to sleep apnea or snoring. And obstructive causes. So these are mostly the causes of snoring. Okay, so I'm discussing the causes of snoring. In children, it is hypertrophied adenoids and tonsils, whereas in adults, it is due to obesity, short neck or thick neck, and more than 40 years. Alcohol consumption also predisposes. Drugs like sedatives, hypnotics, antihistaminics, and antiepileptics. So what are the obstructive causes in the nose? So the nose, nasopharynx, like deviated nasal septum, macroglossalum, the tongue is bulky, large base of the tongue, nasal polyp, and chronic obstructive pulmonary disease, COPD. These all will cause snoring. Okay, and hypertension. Sometimes hypertension also causes snoring. So how does the snoring occur? What happens is during inspiration, when there is partial obstruction to airway due to relaxation of the muscles of pharynx and collapse of the soft tissue of pharynx and supraglottis, it results in the vibration of soft palate, tonsillar pillars, and base of the tongue, producing snoring. So what happens during inspiration and expiration? Inspiration means you're taking in air, right? So when you're taking in air, the airway the airway gets closed, and the muscles should be totally relaxed. If it is but means it should be actually contracted. Sorry, when your inspiration, the muscles should be totally contracted, and that will help to raise the pressure in the lumen of the respiratory tract, and the inwardly, as you know, Bernoulli's theorem, right? At one side, if one side the pressure is more and the other side is the pressure is less, the air will move towards the lesser pressure side. So when the intraluminar means inside your larynx or the bronchi, if the pressure is more and the pressure outside, that is ambient air, is less, then the air will be drawn inside. So that is inspiration. So how, while inspiration, the muscles of the pharynx should be contracted, but if due to some reason if they are getting relaxed, so due to the relaxation of the muscles of the pharynx, the collapse of the soft tissue of the oropharynx and supraglottis will occur. So what will happen? So it will result in the vibration of the soft palate or tonsillar pillars and base of the tongue. So that will produce a sound known as snoring. So during inspiration, when there is partial obstruction to airway due to relaxation of these muscles, resulting in the vibration of these structures like soft palate, tonsillar pillars, and base of the tongue, they will produce a sound known as noisy breathing known as snoring. So obstruction is generally at the level three levels, that is at nose or palate or tonsillar pillars and hypopharynx. So these are some of the areas. Okay. So this is the diagram which will show you different levels of obstruction. Yeah, so number one, this is the number one area. Okay, so this is the number one area, that is the nasopharynx. You can see this is the nose and this is the palate. This is the hard palate. This is the soft palate. So the structures above the soft palate is known. These are the nasopharynx. This is the nasopharynx area. This is the eustachian tubal area. Okay, okay, you are able to see, right? So any level of obstruction at this area will generally cause a voice known as stutter. So this is what this is level one. So what is level two? So this is the level of palatine tonsils area. Okay, so this is the tongue and this is the oropharynx area. So this is the nasal, this is the oropharynx. So any obstruction at the level of oropharynx, that is at the level of tonsillar fossa or at the level of pillars, that is level two of obstruction. Where is level 3? Level 3 is at the base of the tongue. So this is the tongue and this is the base of the tongue going towards the epiglottis. Okay, so this is the epiglottis. Okay, sorry, this is the hyoid bone, this is the epiglottis. So any obstruction at the level of base of the tongue or at the valvular area, that will cause the level 3 of obstruction. And level 4 is supraglottis. So this is at the supraglottis. So level 1 is nasopharynx, level 2 is oropharynx, level 3 is base of tongue, level 4 is supraglottis. So these are the four level of obstructive levels of the airway, where the airway get compromised, and due to that some sound is produced, that is known as snoring. So what are the clinical features when the person comes to you? The person will tell you that generally while sleeping, the mouth is open. Most of the time, the mouth is open for him, so that's why he's able. The sound is more. So open mouth breathing during sleep, noisy breathing, And patients, the patients with severe obstructive sleep apnea, they have to means they tend to have very narrow retrolingual airway. Retrolingual, that is behind, posterior to your tongue. So your tongue is there and behind, like this. See, retrolingual area is this one. Okay, so this is the retrolingual, this is the lingual tongue area. So this is the retrolingual area. When if this most of the patients with severe obstructive apnea will have a narrow retrolingual area, which is the major site of obstruction in severe OSA. Apneic spells during deep sleep. Deep sleep is generally NREM stage 4. Okay, so that may be due to central or obstructive. In central type, apnea stimulates. So what happens is, when the patient is having apnea, that is not able to breathe, then some input has to be sent to the brain that okay, now the oxygen saturations are getting down, so you need to breathe. So in the central type, the apnea stimulates the center and breathing starts. While in obstructive type, in spite of efforts, breathing does not start and there is loud snoring. Abnormal movements like kicking, sitting up, etc. also take place. If the patient has a central type of sleep apnea, then as soon as the apnea stimulates the brain, the person will start taking heavy breathing, and the oxygen saturation will come to normal. But if there's an obstructive sleep apnea, in fact, the brain is getting the inputs, and brain has again given the output to breathe more for the accessory methods of the respiration, to breathe more or to change your side of the sleep, anything. But still, after making these efforts, also if the apnea is not able to control, then it is an obstructive type. Central type, when the brain has given you an output, you will start breathing. So this is how you can differentiate between a central and a obstructive type of sleep apnea. In obstructive sleep apnea, apnea leads to hypoxia. Apnea for longer time will lead to hypoxia, and that hypoxia will cause pulmonary constriction leading to congestive heart failure. So this is one of the most common complications seen with the patients of obstructive sleep apnea. Long standing obstructive sleep apnea people will have hypoxia, and that will predispose to pulmonary constriction leading to congestive heart failure. So they are in the patients who are very with morbid obesity and long standing OSA. If they are not treated, then they are predisposed to congestive heart failure. They have breathlessness and sweating. So breathlessness and sweating are generally seen. Body mass index is more. So BMI is generally more for all these patients. And when you do an oropharyngeal examination, you can see hypertrophy tonsils, palate, and a massive uvula, or sometimes a mass in the nose. So all these can be seen when you do an oropharyngeal examination. There is a questionnaire known as Epworth Sleepiness Scale, where you give a questionnaire to the person to know the degree of the severity of that symptoms of the OSA. So he will be. We have to ask him to rate it accordingly, like 0, 1, 2, and 3. That's how it's not 0 to 4. Actually 0, 1, 2, and 3. Whereas 0 is you don't get sleep. Means you don't do off. Sometimes you get dose, or some one is sometimes you get dose. More, two is more often. Three is every time. So 0, 1, 2, 3. So in different situations like sleeping while sitting and reading, means when the person is sitting and reading, he sleeps. If he sleeps more oftenly, then it is type, then he will mark it as 3. If he doesn't sleep, then it is 0. If sometimes he sleep, it's 1. So like that, in different conditions like sitting and reading, TV watching, or traveling in a car or public transport, sitting and talking. So all the so a set of questions will be given. It has to mark it from 0 to 3. That is, 0 is he doesn't sleep, 1 is sometimes he sleeps, 2 is often, and 3 is more often. More often he's sleeping, then it is 3. If this according to these numbering, if it's more than, then we have a scaling like this. Okay, this is for the level of OSA actually. But similarly, according to this only episode sleepiness square, if it is more than if it is around 15, then it is definitely a severe type of OSA. And this is one of other index known as latency time of less than 4 minutes. Means sleep latency, if it's less than 4 minutes or not, we sometimes we calculate nocturnal polysomnography. So this is the gold standard investigation. If you are suspecting an OSA, then you have to the first investigation which you need to do to confirm this disease is nocturnal polysomnography, which includes electromyography (EMG), electroencephalography, that is EEG, electrocardiography, that is ECG, and oximetry. So all these four are studied. The overnight the person is sleeping, and we connect the patient to EMG, EEG, ECG, and oximetry. So all these four categories are measured, and accordingly we come to an decision that whether the patient is having which type of sleep apnea, whether it is severe, moderate, or whether it is a central type of sleep apnea, whether it's an obstructive type, or whether it's a moderate, severe, or a mild type of OSA. So all these can be classified by knowing by doing this investigation, that is nocturnal polysomnography. So whenever you are asked what is the gold standard investigation for obstructive sleep apnea, so the only answer should be your polysomnography. Computed tomography also we do to see the retrolingual airspace, and MRI imaging of the upper airway can be done to see the soft tissue of the oropharynx, whether any soft tissue swelling of the oropharynx is there. MRI and CT will help you in that. Sometimes we also do a cephalometry to assess the site of obstruction in sleep apnea syndrome. It is accurately taken lateral head X-rays in which relationship between soft tissues and bony points is measured. So cephalometry is done in some cases to know the site of obstruction. So there are various investigations. We take a detailed history, we do a detailed examination of ENT, then we do a PFTs, pulmonary function test. We also do a flexible fiber optic and nasal endoscopy to know the level of obstruction, radiographs of the nose, paranasal sinus, and PNS, rhinomanometry, sleep latency test, nocturnal polysomnography, CT, and cephalometry. So what are the complications of OSA? Complications of OSA. The patient might be predisposed to have cardiac arrhythmias, CVA, cerebral vascular accidents, angina and myocardial infarctions, CHF, congestive heart failure, cor pulmonale and chronic heart disease, hypertension. He might get systemic and pulmonary hypertension, peripheral edema, polycythemia, and the patient will have excessive daytime somnolence. That is, the patient will be sleeping daytime, more in the daytime. Accidents, so that will result in accidents during driving vehicle or operating dangerous machines, less exercise and more weight gain, and more severe sleep apnea. Okay, so all these are the complications. Then comes the treatment part. Okay, so try to understand this this one. This might look to you a bit confusing, but it's very easy actually. How to do a non-surgical treatment when the patient comes to you with sleep disorder breathing, and you have to categorize him snoring without apnea or with an apnea. If there is no apnea, then you do a palatal surgery, UPPP, radio frequency ablation, or laser assisted. Means there is no apnea, only snoring is there. So that is due to some anatomical problem. So there is no problem with the brain and all. So it is generally only due to some anatomical obstructions the patient is having this sleep breathing disorder. So you do a palatal surgery or a radio frequency ablation or a UPPV. All these are done. But if the patient is having apnea, then you will do a polysomnography, and that will you will calculate the respiratory disturbance index, that is hypopnea index. If it is less than 10, then you will again go back to do all these surgeries. But if it is more than 10, then you have to do you have to check for all this stuff, all the other conditions, like night time, how much what's the oxygen saturation you need to know, or dental device. You can give some obturator so that there is no vibration, means the snoring is due to some obstruction, right? So you give some dental devices, and CPAP, continuous positive airway pressure, or BiPAP. So these are used. These are the non-surgical treatments. Okay, I'm not talking about the surgical. So you can go for a dental device, you can go for a continuous positive airway pressure, that is known as CPAP, or BiPAP is bi-level positive airway pressure, or anatomic abnormality and potential sources of airway like cephalometrics. If it's there, we need to understand. If it's an adenotonsillar hypertrophy, we'll remove it. If it's a mid-phase or deficiency or retrognathic, means somewhere at the retrolingual area, we can go for a maxillomandibular advancement. If that is also failure, then we can go for a tracheostomy. If it's a nasal obstruction, then we can go for a surgical correction. If it's a retrolingual obstruction or some problem at the palate area, then you go for a tonsillectomy, or you base of the tongue also you can resect something, some tissue you can remove. If that all failure, then you go for mandibular osteotomy with hyoid suspension or radiofrequency ablation of the tongue. If that is also failure, then the last thing is tracheostomy. Okay, so you start reading from here. Sleep breathing disorder is there. So first you need to understand whether the patient is having with apnea or without apnea. Without apnea, directly go for surgery. If it is with apnea, then you do a polysomnography and you calculate the respiratory disturbance index. If it is less than 10, go for the surgeries. If it is more than 10, then you have to check why it is more than 10. You can go for a dental device. You can go for a CPAP or a BiPAP. If it's an anatomical one, if it's due to adenotonsils, remove it. If it's due to mid-phase deficiency, then you can go for a maxillomandibular advancement. If that also fails, go for tracheostomy. If it's nasal, due to nasal obstruction, go for surgical correction like septoplasty or SMR. Or due to some FES, if it's due to polyps, you can go for a FES. If it is due to retrolingual obstruction, go for a mandibular osteotomy with hyoid suspension. If it is due to uvulopalato-pharyngoplasty and due to tonsillotomy, due to tonsillitis, then you go for these surgeries. And if it fails, you go for mandibular osteotomy and hyoid suspension. If that also fails, then you go for a tracheostomy. So the non-surgical treatment is behavioral modifications. Though may reduce snoring and OSA, especially in mild cases, patients' complaint is usually a problem. You can ask the patient to change some of the behavior, like don't sleep on supine, have frequent meals, and obesity has to be decreased. So you have to ask him to do some lifestyle modifications. Positional therapy: the patient is advised to sleep sideways rather than on the back, and a rubber ball can be tied to the back of the pajama to prevent the patient to adopt supine position, which aggravates the symptoms. You can go for a CPAP, that is nasal continuous positive airway pressure. So this is the most effective. Actually, the first treatment that is advised to the patient with the OSA is CPAP. We ask the patient to go for a CPAP. So it is a sort of a pneumatic splint to airway and increase its caliber. So we there's a small splint provided, so that will keep your nose open, and due to and that is actually it's a snugly fitted to at the nose, over the nose, and some continuous positive pressure is pushed through the nose. So that will that air will reach the lung, and the patient will be having airflow, continuous airflow. Though it is 100% effective in treating OSA, patients' complaint is not very good, because about 30% of the patients eventually stop using this, because that's not compliant enough. It's very the patient to wear the whole night. The patient, most of the patients doesn't like it. So if they start having CPAP, less than 1 month, there's at least 30% of the patients will stop using it, because an airtight mask is kept over the patient's nose with the help of a strap wrapped so around the head. So that is a bit of discomfort to the patient. So most of the patients stop using this CPAP. The optimum pressure for opening the airway. The optimum pressure for opening the airway is determined during sleep study, and it is usually at 5 to 20 centimeters of H2O. So this 5 to 20 centimeters of H2O pressure is maintained in this continuous pressure CPAP, and the airflow is maintained to be continuously. We have another one is BiPAP and APAP. So these are modifications of the CPAP. So they have a little better patient compliance, because bilevel it delivers positive pressure at two fixed levels. So a higher inspiratory and a lower expiratory pressure. So at two different levels this works. So that's why BiPAP is has a better compliance than CPAP. Auto titrating PAP, that is APAP, which continuously adjusts according to the pressure difference that adjusts itself. So this is the first level of treatment given to the OSA patients, that is positive airway pressure. Either it may be continuous, that is CPAP, or bilevel BiPAP, or an auto PAP. Okay. Intraoral devices, which I was telling, dental devices, a tongue retaining device means while sleeping, if the tongue might be falling back, that's why there is some obstruction at the base of the tongue or at the oropharyngeal level. So tongue retaining devices and mandible advancement device that will hold the tongue or the mandible forward during the sleep and keep the airway open. So these are some of the dental devices that can be used for the patients. But actually, as with the CPAP, similar to the CPAP, the discomfort and poor compliance are the major concerns for this on intraoral devices. So you ask the patients to go for a surgery, for a lifestyle modification, but still there is no improvement. Then next you will ask the patient to have a use some CPAP or a intraoral device. If at all the patient is not compliant enough and he doesn't have any improvement in the symptoms, then if it's an obstructive sleep apnea, then you go for the surgical treatment. If the site of obstruction is at the nose or the nasopharynx, you do all the surgeries: septoplasty, turbinectomy, adenodectomy, nasal wall reconstruction, removal of polyps and tumors. If it's at the palate and the tonsils, so all these surgeries, tongue, so these surgeries, and jaw. So these are some of the surgeries which we do at different levels of the obstruction. There are many, so I won't read it out. I'll share you this PPT. You can have a look. One of the most commonly done surgery, I'll discuss something about this uvulopalatopharyngoplasty, that is UPPP. It's U triple P. So this is one of the most commonly done surgery for the patient with OSA. So this is technically easy operation, is the most common surgery performed for OSA. The oropharyngeal airway is enlarged in an anterior, superior, and lateral dimensions. It is a type of radical tonsillectomy. The tonsils and uvula are removed along with the posterior edge of the soft palate. The anterior and the posterior facial pillars are sutured together. Similarly, the nasal and the oral side, because of the cut edge of the soft palate, are sutured together. Patient usually stays for 1 or 2 days in the hospital. So what you're doing is, you remove, means generally how do we do a tonsillectomy? We just remove the tonsil from the tonsillar fossa. But after removing the tonsil, you also remove some part of the uvula and soft palate, and we suture these two pillars, anterior and posterior. So that will improve, that will increase the dimensions of the laterally and anterosuperiorly. So in the anterosuperior and the lateral dimension, the airway is enlarged. And oral at nasal and the oral side mucoses of the cartilage of the soft palate are sutured together. So this is known as uvulopalatopharyngoplasty. Some other surgical procedures like hypopharyngeal and base of the tongue procedures. So in whom you do this hypopharyngeal and base of tongue procedures? When the patient is having morbid obesity, when that is more than 31, mandibular skeletal deficiency is there, or lateral cephalometric radiogram that is less than 11 mm, flexible laryngoscopy, that is where when the patient is having narrow retrolingual space, then when you do a Muller's maneuver, the lateral pharyngeal wall get collapsed. So in these conditions, you go for the hypopharyngeal at the base of the tongue procedures. When the apnea hypopnea index is that is severe, if it's moderate more towards the severe type of OSA, then you go for the other these procedures, hypopharyngeal and base of tongue procedures. So what are these? Partial midline glossectomy, tongue base radiofrequency ablation, advancement genioplasty with hyoid suspension, hyoid myotomy and suspension, mandibular and maxillary advancement. Just remember these names. We can do a glossectomy in the midline. Means midline, if you do a glossectomy, and means the large, when the tongue is very large enough and that is falling back towards the tongue, towards the oropharynx, and causing this sleep apnea, then you can do a glossectomy in the midline and remove some of the tissue. Tongue base is large enough, you do a radiofrequency ablation there. Genioplasty is you pull the tongue towards outside, with and suspend to the hyoid bone. So that will prevent the falling back of the tongue. Hyoid myotomy is done, suspension is done, or mandibular or maxillary advancement. So they are brought in front so that the retrolingual space is getting wider and the patient is devoid of these symptoms. Nasal surgeries, as we have discussed, we do a lot of surgeries. Tracheostomy is, though neither preferred by surgeon nor liked by the patient, this gold standard treatment of OAC is almost 100% effective. If we do a tracheostomy, then definitely the air will go from here and the patient will not have any sleep apnea. But tracheostomy, if you are doing it for a longer time, it's very problematic for the patient. So tracheostomy bypasses the upper airway entitled, but needs daily care throughout the life, which is the major stumbling block. It is probably the first line of surgery in very severe OSA or in those who are significantly obese or debilitated. So initially, when in severe OSA or in those who are significantly obese, you initially go for tracheostomy, and then with other treatments, when if the patient's condition is improving, then you can take out the tracheostomy. So I hope you have understood a bit. I will share you this topic. You can once again go through this. Okay. Thank you so much.